but it's lovely to have you. Welcome to the ISPAR conference 2021. It's lovely to see so many familiar names and faces. Okay, looks like people have joined us well. Okay, so I'm hoping, and can someone give me a nod to say that you can see the screen? Yeah, good. Abby, funny, I can see you. Fantastic. Okay, right. So welcome to our conference. We're going to be live streaming this conference on YouTube, which will go across our university also. So the speakers have all agreed for their presentations to be shared. So just to let you know, if you do have your cameras on, you may be in view. We have an exciting programme today and tomorrow and Thursday. And this is our annual conference that we have to celebrate the Institute for Sport and Physical Activity Research. So our conference is on improvement through movement, performance, health and wellbeing across the lifespan. I'm Professor Angel Chater, I'm the Director of the Institute, and on behalf of all of our organising committee and the whole of our membership of ISPAR, welcome to our conference. We embrace an active campus, and so wherever you're watching, we encourage you to stand or move around during the presentations. We really encourage people to sit less, so feel free to walk around whilst you're watching us. So as I said, we're celebrating ISPAR research. Novel research within science sits at the outer layer of human knowledge. It pushes boundaries of current science and it helps us to expand on things we didn't know before. So our focus is on creating research that has impact, and today is about showcasing the talent that we have within ISPAR. So to help us to have impact, please share what you hear with your networks and your colleagues. You can tag us in Twitter using ISPAR_UOB. We also have a junior institute, which is led by our postgraduate research students, and their Twitter handle is at ISPAR Junior. And we sit within the School of Sports Science and Physical Activity within the University of Bedfordshire, and so again that's at UOB_SSPA. We have a SPED Sports Science department that manages all of our sports science stuff. You can tag us there and use the hashtag ISPAR 2021 and ISPARconf. And just to give you an overview of all the people who are involved in ISPAR and the things that we get up to. This is our fantastic group of staff and postgraduate research students. ISPAR wouldn't be an institute without all of these people, many of whom you'll hear about over the next 3 days and hear about their research. But I just want to thank all of these people for making our institute what it is. Our institute is made up of 3 research centres. We have the Centre for Physical Education, Sport and Human Movement, which is led by Dr. Joanne Hill, and they will be presenting on their research tomorrow from 4 to 6 p.m. We have the Centre for Health, Wellbeing and Behaviour Change, which is the research centre that I lead, which you're going to hear lots about today. And then we have the Centre for Physical Activity and Sports Performance, led by Dr. Rebecca Jones and Dr. Jeff Aldous. And you'll hear from them on Thursday at the same time, 10 till 1. And within all of our research centres, we have special interest groups, and each of those sit within different areas of specialism that our staff and PGR students are working on. We also have a community exercise clinic, and this is led by Kev Wild, who's our exercise on prescription specialist. We accept referrals from individuals living with long-term conditions such as obesity, cardiovascular disease, cancer, mental health and bereavement. And clients who join us follow an 8 to 12 week programme of structured exercise. They have health education and behaviour change sessions. And it's facilitated by our qualified staff in exercise on referral and students. And we welcome anyone who's listening who's in our local community, particularly those who live within the Bedford area, to come along, refer yourself in, through one of your health professionals. We also have a human performance centre, and this works with a range of individuals to optimise health, fitness and wellness. We work with highly trained sport and exercise scientists to help people to reach their fitness goals, working with athletes, individuals who want to support weight loss and so on. So again, if this is you and you'd like to work with us, please do get in touch. I'd like to end just by thanking the people who have supported the funding through ISPAR. We receive funding from a number of different organisations, through research councils, through charities, through our active partnerships, and many other organisations that we work with. So big thank you to everybody who supports our research. And thank you to you for being with us. Thank you for joining our conference. You would have been sent the link to our programme and abstracts booklet. So hopefully you'll be able to get a bit more detail about what we get up to in there. And if you want any more information, do get in touch. Okay, so it is now my great honour to introduce our keynote speaker for our day one of our conference. Our keynote is Dr. Stacy Clemes, and she is a reader in active living and public health at Loughborough University. Stacy has a huge list of publications in the area of physical activity and health behaviour to improve people's health through the life course. And in particular, she's been working on an NIHR public health research grant, which is looking at a multi-component health behaviour intervention to improve and reduce sitting time in heavy goods vehicle drivers. And this is called the SHIFT programme. She was also one of the experts for the sedentary behaviour expert working group for the 2019 COM, Chief Medical Officer Physical Activity Guidelines. And we are delighted to have her as our keynote speaker today. So Stacy, I can see you shared your slides. Thank you very much. Over to you.
Thank you very much, Angel, and thank you very much for the invite to speak at your conference this morning. Delighted to be here. So as Angel has said, my work really has focused a lot over the last few years in looking at trying to improve the health of our heavy goods vehicle drivers. And I'll talk a bit more about introducing this project shortly. But hopefully the project that I'm going to be talking about kind of sits quite nicely within kind of the research conducted within the ISPAR Centre. Okay, so just first of all, I just want to give you a bit of background to this study and really talk about why are we looking at this particular occupational group. And probably actually what I'm going to be talking about today is quite topical. There doesn't seem to be kind of many days go by at the moment where we're not kind of faced with a news story about the shortage of heavy goods vehicle drivers that we're suffering in the country at the moment. So probably this is actually quite in the forefront of most people's minds. And again, you may have experienced it firsthand, perhaps going into the supermarket and seeing some empty shelves in your area, or certainly seeing some of the popular news articles on this at the moment. So really, as we probably know now and what we've experienced lately, truck driving or heavy goods vehicle driving is very much essential for our UK economy. And it's estimated that about 75% of all goods delivered in the UK are transported via road freight. And in normal times, the logistics sector within the UK contributes over about 13 billion to the UK economy. I'm saying kind of during normal times, these figures are pre-COVID figures, but we all know things have been a bit different over the last 18 months or so. There's around about 300,000 heavy goods vehicle drivers employed in the UK. Again, this number has been decreasing in recent times, and I'll touch more upon this over the next couple of slides. But just want to define heavy goods vehicle. So a heavy goods vehicle is any vehicle with a weight between 3.5 and 44 tons. So it's quite a big range in what we would consider a heavy goods vehicle. But I'll be using probably the term HGV or heavy goods vehicle throughout this talk. Okay, so if we think about working as a heavy goods vehicle driver, the working profession is quite hazardous. And heavy goods vehicle drivers have recently been kind of identified as working within one of the kind of most occupational hazardous professions there is. And this talk, again, is really going to focus on what we're referring to as long distance heavy goods vehicle drivers. So by long distance, I mean these are individuals who make just 1 or 2 delivery stops as part of their working day. So they pick up their vehicle and their goods, and they might drive for, say, up to 4 hours, have a rest before they carry on to kind of their destination. They might then unload their goods, and then they return perhaps to their original depot. So these individuals, again, spend many, many hours of their day driving. I just wanted to contrast these individuals to perhaps more kind of domestic HGV drivers who may make many delivery stops throughout the day. So these individuals are frequently in and out of their vehicle, breaking up their driving quite a lot. So the occupational group that we've been targeting in our research are these more longer distance drivers, the drivers who are spending kind of many hours of uninterrupted driving throughout the day. And if we think about these individuals, again, as part of their occupation, they're very much exposed to a huge range of health-related risk factors. So obviously, not surprisingly, they spend a large proportion of their day sitting. I would call these individuals people working in compulsory sedentary occupations. Again, a number of years ago, we've done a lot of work with office-based workers. We're still doing projects with office workers now where we've tried to reduce office workers' sitting time. So the way, or my background very much is in reducing sitting and increasing movement. So a lot of my early work in the sedentary behaviour field has actually been focusing on office workers. But office workers perhaps are relatively kind of straightforward to intervene with. You can give them a sit-stand desk or encourage them to regularly break up their sitting time. But these strategies, of course, you can use with drivers who obviously have to be driving. They've got no choice, that they have to sit for prolonged periods of time. And really, it was these challenges associated with this occupational group which made us kind of start doing some research in this group in the first place a number of years ago. So of course, drivers, by nature of their job, as I said, they spend long periods of time sitting. They work extremely long hours, which also means that they have very limited time for physical activity. If we think as well about their typical maybe rest stops, again, everyone's probably very familiar with a typical greasy spoon cafe that attracts drivers, or if we think about our motorway service stations, they are heavily populated with unhealthy food choices. So drivers, again, not only are they spending lots of time sitting and quite inactive, they're also exposed to perhaps not the most healthiest of food options. Again, thinking about the nature of their job, most are given quite tight delivery schedules, but a lot of their job is really outside of their control. So they're reliant, of course, on the smooth working of our roads. So again, if they come across a delay on kind of any of the roads, and obviously that will hamper their delivery schedules, etc., and cause extra stress. So again, as part of their job, there's a lot of things that are really outside of their control, which can again increase levels of occupational stress. They also perhaps have to deal with maybe unpredictable behaviours of other drivers as well, which can exacerbate their stress. The logistics sector also works 24/7. So again, most drivers within the sector work some kind of working in its own can cause kind of increased health risks. Again, due to the shift work that the drivers tend to do and due to the long hours that they work, they tend to be quite sleep deprived as well. So there's a whole host of different factors which really interact, which really impacts the health profile of drivers. We published a systematic review in this area last year, where we actually reviewed kind of evidence globally on the health profile of truck drivers. And again, perhaps unsurprisingly, we concluded from this review that they exhibit multiple unhealthy lifestyle health behaviours, and they exhibit typically higher rates of obesity and cardiometabolic risk factors than that's seen in general populations. It's also been really highlighted that kind of the strains of their occupation, their poor health status really can exacerbate their risk of accidents, and their rates of chronic diseases. And it has been reported that HGV drivers are among those with some of the lowest life expectancies in comparison to other occupational groups. But really, despite this evidence, very little has been done over the years to actually target the health of these drivers. Also, really to exacerbate perhaps the unhealthy working conditions of this occupational group, the group have also been highlighted as an ageing and now shrinking workforce. So for many years in the UK, the average age of a HGV driver has been about 48 to 50 years old. And we all know, and I mentioned it at the very beginning of the talk, that at the moment in the UK, we are experiencing a real shortage of drivers, which has now been reported to be reaching a crisis point. We always have had a shortage of drivers. So back in 2015, it was estimated that we have a shortage of drivers by about 60,000. But this in just the last year has risen to an estimated 100,000. And of course, we have now started to see the impact of this through perhaps deliveries not being made. And again, a lot of news articles have been published in the last couple of months highlighting the driver shortage. And I've just got a few headlines here, which I've kind of put together in terms of when I was preparing this talk. So again, lots of issues about kind of how perhaps our economic recovery from COVID is being threatened at the moment by the shortage of drivers. The BBC have included a number of articles on their news pages as well about the seriousness of the driver shortage. Perhaps one of the first articles, again, I don't know if people remember, that came out about this was how we might be seeing a shortage of Haribo sweets caused by shortages in drivers. Haribo is not the only company affected. Again, there's been reports that Nando's have had to shut some of their restaurants due to shortages of supplies. Wetherspoons have been reported to be running low on some beers due to driver shortages. BP have had to close some sites temporarily, and Morrison's have warned of shortages of food supplies and increases in price linked to this. So again, I think for most of us, it's very much at the forefront of our minds now how important drivers are to our economy. Again, as I said, this problem isn't really that new. So again, back in 2015, an all-party parliamentary group for freight transport actually recognised the shortage of drivers, and they recognised as well the ageing workforce. And they published a report where they identified kind of the health concerns of this ageing and at-risk workforce driving a vehicle, which they referred to, that could turn into a 40-ton missile if the individual obviously suffers a health event whilst driving. They recommended back in 2015 that actually more needs to be done in this industry to address the health risks associated with drivers and to try and make the occupation more attractive to encourage younger people to join this group. But again, the health of our HGV drivers, again, it's extremely important. It is not only affecting kind of the individual in this case. We know that certainly that the health of drivers can have a wider public health impact. So again, if an individual driver is to suffer, for example, a cardiovascular event whilst driving, then this could potentially have devastating consequences for other road users. So again, it really should be a high priority that we tackle the health of this group. And again, of concern, in 2017, it was reported that whilst HGVs only account for about 12% of motorway traffic on vehicles, actually 41% of motorway fatalities in 2017 were linked to HGVs. So again, further evidence really to highlight kind of the importance of actually doing some work with this occupational group. Okay, so in response to this, we have created our intervention. This is referred to as the Structured Health Intervention for Truckers. And I'll just say a bit about how this intervention came about. So SHIFT, as we call it, is a multi-component, theory-driven lifestyle health behaviour intervention, and it's predominantly designed to lead to positive changes in physical activity, diet, and sitting in HGV drivers. We actually started working in this area in about 2013, so we've been working in this group for quite a long time. Our intervention has been informed by extensive public and patient PPI involvement, and a series of earlier research. So some of the early research which informed where we are now included a surveillance study with a relatively small sample of HGV drivers, where we looked at their health profile, we looked at their health behaviours, and from that we were able to determine perhaps that it's really important to target their physical activity, their sitting time and their diet. We had a qualitative work researcher who actually did lots of qualitative interviews with drivers, and he joined the drivers during their driving shifts. So he went on about 24 trips with drivers and actually chatted to them throughout their day. And so he could actually see firsthand the challenges that they face in terms of leading a healthy lifestyle whilst at work. From kind of our surveillance work and our qualitative work, we then created the first iteration of Shift, which we tested in, again, a small sample over a 3-month period using a pre-post design. And we did a full process evaluation on that. So then we further refined our Shift program based on what we learned from our pilot testing. And that then led us into applying to the NIHR for a randomized control trial to fully evaluate our Shift program. So the rest of my talk, really, I'm going to be focusing on aspects of this trial and what we did and what we found. And I should say that I actually submitted the final report to the NIHR on this work last week, literally last Tuesday. So everything I'm going to be presenting now is very much kind of hot off the press. And I think you guys are the first to really hear about what we've found. So we partnered for this study with DHL, and we recruited participants and worked with 25 different DHL sites. So this study was conducted throughout the Midlands region of the UK, across these 25 different depots. And I just want to share with you now just some of the marketing material that we used initially. So we had quite a big recruitment campaign across our participating sites to raise awareness of the study with drivers. So these are just some of the posters that we had designed to initially inform the drivers of the study. So I'm going to talk initially now about what is Shift. So the whole Shift program includes initially a detailed health assessment. The health assessment involved a 2-hour meeting, kind of one-to-one meeting with a trained researcher. These health assessments took place within the workplace environment of our drivers. And they typically included weight, body composition, blood pressure, finger prick blood samples, which were analysed for HbA1c, and LDL, HDL, and total cholesterol. We also issued our drivers with a wrist-worn Genie Active monitor, which we used to measure their sleep over the following 8-day period. And they also wore an Active PAL monitor on their thigh, which we used to measure their physical activity and their sitting time. And I should say that in this trial, physical activity was our primary outcome, and our main outcome was daily step counts. Drivers also completed a range of self-report measures where we looked at aspects of their mental health, their musculoskeletal comfort, their work-related kind of psychosocial variables. So we collected a lot of data from our participants. So then participants randomized to the Shift arm. After the health assessment, they then attended a structured education session. This was a 6-hour education session. It was a group-based session, which again took place in the depot. And there was about 4 to 6 drivers that took part in each session. And the education session really focused on physical activity and diet. It also focused a bit about smoking and alcohol intake, but the main focus was really physical activity and diet. And in the education session, drivers were really encouraged to think together of ways they could overcome challenges associated with their kind of inactive lifestyles, and also how they could incorporate more healthier dietary choices into their daily routine. Within the health education session, the drivers were given as well some resources, which included some grip strength devices, resistance bands and resistance balls. And we created a cab workout for them. And this came from our earlier work where drivers told us sometimes they can drive 4 hours to a stop, but they're not actually allowed to leave their cab due to health and safety of loading, unloading around them. So we've created this little workout that they can actually do whilst in their vehicle. We explain the workout and we show the drivers the different activities they can do in the education session. They're then given the resources they need for that, and along with a little booklet which talks about a whole range of different exercises that they can do. We also give drivers a Fitbit. So they were given the Fitbit, they could keep the Fitbit, and they were encouraged to use the Fitbit to increase their step counts. We would also offer the drivers health coach support. This was via a text messaging service manned by our research team. And as part of the health coach support, we would give the drivers step count challenges, which would take place every 6 weeks. The intervention in our main trial lasted for 6 months. So after the 6-month period, drivers returned and they had a second follow-up health assessment. And I should have said as well at the beginning, as part of the health assessments, drivers actually had detailed feedback on their health profile. So they took away all of their results in a little booklet, which explained how their health kind of compared to general population and any risk factors identified. So this is just really an overview now of our trial. So all drivers undertook the health assessments across the 25 depots. They were then randomized at the site level, so at the depot level, into either our shift arm or our control arm. So all control individuals as well benefited from the detailed health assessment. They were then kind of contacted again in 6 months for the follow-up measures, and it was intended that we would measure them again after 12 months to look at the sustainability of the programme. Within our funded trial, we had 2 phases. We had an internal pilot phase where we started with 6 depots initially, just to check that what we were proposing was feasible. And then after we were able to demonstrate it was feasible, we moved on to our main trial phase. The highlighted text in the main trial phase just kind of highlights some of the changes that we made. So the trial initially was supposed to finish last year, but due to a number of delays experienced and COVID, it was pushed back to finish this year. We also had one of our pilot sites that had restrictions around drivers wearing the active PAL. So to compensate for this, we recruited another site. So that's how we ended up with 25 sites. Our power calculation originally defined that we would need 336 drivers. We actually recruited 382 in the end. Just want to mention very briefly about kind of the impact of COVID on our research. So as I said, our primary outcome was intended to be measured at 12 months. Just as we were about to start our 12-month assessments, in our main trial phase, unfortunately, COVID came along, which suspended the whole trial. So due to all the uncertainties with COVID, it was then agreed that we would actually change our primary outcome to the 6-month follow-up assessment point. Okay, so just a brief overview now of our sample. So as I mentioned, we had 382 drivers complete or take part in the study at baseline. The average age of our sample was 48 years. So again, very reflective of the average age of HGV drivers nationally. Very concerningly, altogether 89% of our drivers were classified as being overweight or having obesity. So again, confirming the poor health status of this group. Again, 51% had pre-hypertension and 28% had hypertension. 84% had clinically elevated LDL cholesterol levels and 67% had high total cholesterol. So again, emphasizing kind of this group and the need for an intervention. Looking at the physical activity data at baseline, they were kind of sitting for about 11 hours per day and accumulating kind of relatively low levels of light and moderate to vigorous activity. And the average step count was just over 8,000 steps per day. And again, one kind of area of concern that we found within this study was the sleep duration of the drivers. Again, we found that they had very low levels of sleep on average. So most drivers were not accumulating kind of the recommended minimum of 7 hours sleep per night, which again highlights a lot of concern. Okay, so just moving on to summarize the main findings. So these are the findings from our study at 6 months, which is our primary outcome. And we found that compared to the control group, participants in the shift arm accumulated just over 1,000 more steps per day at 6 months in comparison to controls. So we did find a significant impact of the intervention on our primary outcome, which was daily steps, which was a good result for us. We also found actually that the shift group at 6 months had reductions in sitting time, slight increases in standing and stepping time, and a small increase in MVPA. When we looked at the data in more detail, all of these differences were largely driven by changes in behaviour of non-work days. And again, in our process evaluation, the drivers highlighted that they found it really difficult to change their behaviour on work day, and most of their changes occurred on non-work days. We didn't actually see any changes in diet, even though in the process evaluation, the drivers reported making kind of changes to their diet, but this didn't come out in the data. We saw a small reduction in weight, but this wasn't statistically significant in our intervention group. And perhaps of concern, we saw as well actually a further reduction in sleep duration across both intervention and control groups in our sample. Okay, so just to highlight some of the challenges that we face working in this group, and it really emphasises that they very much are a high risk and hard to reach group. So again, we suffered a lot of challenges in terms of data collection, going into sites, collecting data, largely due to kind of the 24/7 nature of the logistics industry. Our research team were having to get up in the middle of the night to go to sites to measure drivers. You might think, why am I showing the news article about KFC? You might remember a few years ago that KFC suffered problems with the supply of their chickens, and this was actually linked to DHL taking over the contract. And this issue came when we were doing our study, and at the times we were having a problem recruiting or dealing with one of our sites. And of course, the senior management in DHL were obviously very much tied up. We were sorting out the KFC chicken fiasco that our study kind of got pushed to one side, and that actually caused about a 2-3 month delay in our study. At the same time, one of the locations actually suffered a fire as well, which kind of caused further delays to our study. We also did suffer a couple of sites kind of dropping out of the study due to the closure of their businesses. But again, it really kind of emphasizes kind of the challenges associated with this group. So just to finish off, what do we do next? Our next plan really is to refine our program based on what we've learned from this trial, and hopefully turn it into a professional development training module for drivers, so it can go out nationally to help drivers kind of make better health behaviours. We've also recently been awarded a new grant from the MRC to actually co-create a sleep intervention for drivers based on what we found in this study. And again, due to COVID, actually, we completed a short survey with our drivers, and we found some novel findings that show that drivers that spend time in nature actually had reduced occupational fatigue. So this is another area that we would like to go into, in addition to focusing as well more on kind of diet and how we can further impact drivers' diet. Okay, I'm conscious of time, so I will leave it there. I want to say thank you very much for listening this morning. And again, thank you for the invite. I'm just going to leave you on this slide so you can just see a couple of quotes from our drivers about our programme. But at this point, I'll be very happy to take any questions. Thank you.
Brilliant. Thank you, Stacey. That was an excellent presentation. It's really nice to see a study being presented in such detail and focus. So thank you for that. And as you say, it's hot off the press, so we're privileged to hear about your findings. Right, we do have time for one question. There isn't a lot of time, but has anyone got a question? Feel free to add it to the chat or raise your hand if you do. It's always like this with the first one. Okay, I can ask a question then. Obviously you saw some significant impact on sitting time, physical activity and steps. Oh no, we've got some. Right, we've got a question from someone else. Were you able to isolate which element of shift improved the step count? Okay, so any aspects in particular?
That's a really good question. What we are going to be doing is looking in detail at our process evaluation, which involved a lot of interviews with drivers to try and work out what aspects of the intervention really worked and what maybe didn't work. But certainly one thing that came up in the process evaluation was the Fitbits. The drivers love the Fitbits. And a lot of them found that the Fitbit was extremely helpful and motivating. So I definitely think that having the Fitbit and the step count challenges was kind of a major driver for helping people increase their daily step counts.
Okay, interesting. Thank you for that. I hope you can stay around for a little bit longer. And I'm sure, you know, if anyone's got another question for Stacy, she'd be happy if you added it to the chat here, or you can follow up with an email if you think of something in the future. Okay, I can already see some more questions. And she also leads this centre. Among her varied external roles, she's also the chair of the British Psychological Society's Division of Health Psychology, just making sure I get that right, and she's leading the British Psychological Society's COVID-19 behavioural science prevention task force. Her research really focuses on how we can understand behaviour and intervene in behaviours in a health and disease context. And she works with various populations from children, adolescents, through to adults and clinical populations. Angel has received funding for her research from various sources, including the MRC, NIHR, Diabetes UK, various other charities and local councils. And today she's actually going to be presenting on one of our Research Excellence Framework impact case studies that we submitted earlier this year. So without further ado, I'll hand over to Angel.
Thanks, Julia. I'm on a new laptop, so can you see my screen? Is it on slideshow?
You're fine, yeah. Yeah.
Perfect. Thanks, everyone. Right, thanks for that intro. I wasn't expecting that. And I should clarify, I'm past chair of Division of Health Psychology now. I've very recently stepped down. So I'm delighted to be able to share with you our first impact case study from REF 2021, where we submitted to the Unit of Assessment 24. And our topic was on changing sedentary behaviour, inactivity, health and wellbeing through influencing policy, training and practice. And I just want to highlight the other two individuals who were part of this impact case study, Dr. Daniel Bailey, who was with us at the time but has now moved across to Brunel University, and Dr. Lindsay Smith. So just to give you some context, and I know Stacey's just done a fantastic presentation to give this context of the importance of reducing sitting time, but sedentary behaviour and inactivity are two distinct factors, sedentary behaviour being too much sitting and inactivity being too little physical activity. And on average, we're sitting around 9.3 hours a day, where we're spent in sedentary time, which is defined by posture, so sitting or reclining, and also low energy expenditure, so typically between 1 to 1.5 metabolic equivalents. In contrast, physical inactivity has been described by Sport England as engaging in less than 30 minutes of moderate to vigorous physical activity per week. And there's about 27% of the population at the moment who are classified as inactive, and this has increased since COVID-19. And the rest of the time we've spent a short amount in moderate to vigorous physical activity, light intensity activity, or we're asleep. And there are clear links to health and well-being. Both sedentary behaviour and physical inactivity are associated with increased risks of obesity, type 2 diabetes, cardiovascular disease, poor mental health, and premature death. And a statistic that's cited quite a lot is the 1 in 6 deaths in the UK caused by inactivity. Traditionally, guidelines, policy, training and practice have promoted the engagement in 150 minutes of moderate to vigorous physical activity, but it doesn't always include sedentary behaviour, and it's not always achievable for large population sections of our population. So our underpinning research for this REF impact case study included 6 different pieces of research, which was the maximum we could include. And they've been cited a fairly decent number of times in the academic field. So we've had academic impact also, in particular Dan's paper cited 323 times, looking at breaking up prolonged sitting with light intensity walking, showing that it improves postprandial glycemia. And a systematic review and meta-analysis led by Dr. Neil Howlett, who was at the time one of my PhD students, which has been cited 132 times, looking at behaviour change techniques that help to improve physical activity. So the first 3 papers that were within this impact case study really highlighted that there is a significant influence on total daily sitting time and an increased risk of cardiovascular disease and diabetes. And this is independent of physical activity. This was based on a meta-analysis of nearly 450,000 individuals, and it really highlighted an important distinction between sedentary behaviour and physical activity. Other research showed that there's acute metabolic, cardiometabolic and psychological benefits in breaking up sedentary time with short and frequent bouts of light, moderate and high intensity physical activity in a laboratory setting. And this had beneficial effects on postprandial glucose, insulin and lipid levels, which we know are predictors of obesity, cardiovascular disease and type 2 diabetes. And this has been shown in a number of different populations. And acute improvements were found in cardiometabolic health and cognitive function in response to breaking up sitting with moderate intensity walking breaks in Qatari females, who we know have a high prevalence of a risk of obesity. So there's good evidence that breaking up and reducing prolonged sitting behaviour is beneficial for health. There's a clear distinction between sitting behaviour and inactivity. And there's a need to understand why people sit for prolonged periods of time and to develop evidence-based behaviour change interventions to break up and reduce sitting and increase physical activity, but not just to that 150 minutes, but looking particularly at those people who are classified as inactive. So our team took and takes a behaviour change wheel approach, and the behaviour change wheel breaks down intervention development so that you first define a problem and you highlight what might be leading to that problem in behavioural terms, highlighting determinants of that behaviour through a model called COM-B. And the COM of that COM-B is the determinants of behaviour. It looks at capability, opportunity and motivation. The B obviously being behaviour, and then we look at health outcomes. And there's a 3-stage approach to developing interventions using this behaviour change wheel with 8 different steps. And so we use this approach to develop interventions. First, in our other underpinning research, we looked at how the COM-B can be used to do a behavioural diagnosis of the reasons why people sit for long periods of time. We looked at 25 office workers and we found that they had the physical capability to move around, but they lacked psychological capability in terms of having a knowledge deficit. They didn't really know the guidelines for how much they should break up their sitting for. And they lacked self-regulation ability to be able to move more and remember to move and so on. In terms of motivation, they had reflective motivation. They wanted to move. They thought it was a good idea. They had a willingness to change. But their automatic motivation was getting in the way through their habits and through their emotions and through competing motivations to work on the tasks at hand. They would sit more when they had low mood, and this was getting in the way. In terms of physical opportunity, they felt they didn't have the physical opportunity to move around and stand more at work. They felt they were tied to their desk, and that they felt there was a lack of social opportunity through it being a social norm to sit within the workplace. And so we took this information and we used the behaviour change wheel to map we mapped the COMBI to the rest of the behaviour change wheel to develop an intervention matrix. We mapped this to the quotes that people were telling us in our interviews, and we looked at ways in which we can help to change behaviour using behaviour change techniques from the BCT taxonomy. We also wanted to know what behaviour change techniques had worked in previous research, and so we did a systematic review led by one of our PhD students, now Dr. Marsha Braley, where we looked at the behaviour change reduction interventions in the workplace and found that interventions that were more promising at reducing sitting behaviour would include social comparison, problem solving, demonstration of behaviour, goal setting, substituting behaviour and habit reversal. We also wanted to do the same for physical activity, and so again another systematic review led by now Dr. Neil Howlett, who again was a PhD student at the time, highlighted that interventions are more likely to increase levels of physical activity if they include biofeedback, which might be a heart rate monitor, demonstration of behaviour and behaviour practice rehearsal, which might be exercise classes, and graded tasks, so things like Couch to 5K where you're grading and you're building up. If you want to extend that from 6 months or more after an intervention ends to see if people continue to be physically active based on the intervention, what we found were interventions were more likely to be successful if they included action planning, instruction on how to perform that behaviour, behaviour practice rehearsal, prompts and cues, graded tasks, and self-reward. So we took this information and we developed interventions which we then delivered and evaluated over the last few years. So a summary of our impact in terms of this impact case study, we have, our research has led to revisions to and the development of international and national guidelines, to professional education, training and practice, to changes in occupational health and public health outcomes, and widening societal awareness of the importance of not just being physically active, but also reducing sitting behaviour. So some examples of these, the World Health Organization most recent guidelines on physical activity and sedentary behaviour specifically cites research from our impact case study, highlighting that adults should limit the amount of time spent being sedentary, replacing sedentary time with physical activity of any intensity, including light intensity, to improve health benefits. And this is directly related to the research that Dan had led. We also have our research heavily influencing 2 roadmaps, public health roadmaps for COVID-19 that were published by the British Psychological Society on physical activity and sedentary behaviour, and again really separating those 2 out. Our research has been used as evidence in the first global expert statement on reducing sedentary behaviour in the workplace, and this statement recommends that office workers should spend 50% of their working hours standing or in light activity. It's also led to professional education, training and practice and being embedded in programmes which are now being delivered across several local authorities. We initially co-created the Active Hearts programme, which was a programme for inactive adults at risk of cardiovascular disease and or mental health concerns. And they offer a 45-minute consultation with a follow-up at 2 weeks, 3, 6 and 12 months. We trained the registered exercise professionals who were Get Active specialists in doing a COMBI behavioural diagnosis through using methods such as motivational interviewing and health coaching, and then delivering behaviour change techniques that we had developed in a protocol for Active Hearts. And we do more than education. We didn't just give them some information and leave them. We monitored them every 3 months for it's now, you know, going into its 6th year, where we listen to their consultations with their clients, and we give them audit and feedback on their skills. So this provides fidelity of the intervention, and this is picked up as one of the successes of the programme in the process evaluation, which has been accepted for publication, should be out very soon. So this, one of the programme managers has said, get this right, the training, and the project has every chance of success. We've also had our work cited in guidelines and policy documents. So Sport England has used Active Hearts in their example for their behaviour change design principles. The Local Government Association has used Active Hearts as a case study for best practice on how to support sedentary behaviour and physical inactivity in the community. And Public Health England has included some of our approach in their Achieving Behaviour Change guidelines for local government and partners. Active Hearts is featured in the BPS policy document, Psychological Perspectives on Obesity, Addressing Policy Practice and Research Priorities. And we've trained a number of other health professionals in local authorities to use this approach, including Luton, Epping District Forest and Watford. We've made international impact where we've gone over and trained public health specialists in Moldova. Many of the individuals who are both commissioning services and delivering services over there can't access some of our science because they don't speak English. And so we were asked to go over to speak at an event and to help people to develop their interventions in different realms using some of our science, in particular our systematic review on what behaviour change techniques to use to enhance people's physical activity levels. And this was translated into Russian and Romanian so that individuals could use it in practice. Changes to occupational health and public health include employees at Bedfordshire Police Department, the University of Bedfordshire and Bedford Borough Council, who've all been supported to reduce their workplace sitting, and we have evidence that this has had improvements in their health and well-being. Marsha Braley's PhD, for example, reduced sitting by 18 minutes per day and increased activity by 16 minutes per day, having an impact on things like weight loss. Another project led by Dan highlighted from 89 office workers that there were significant reductions in sitting by about 39 minutes per work shift, increases in physical activity by 12 minutes, and reductions in waist circumference. And Beat the Seat continue to use strategies related to behaviour change in their corporate wellness programme. Active Hearts has received over 4,000 referrals, and a longitudinal observation of 732 adults has shown increases in physical activity of 12,000 metabolic equivalents. So this is the equivalent of either 150 minutes of vigorous activity or 300 minutes of moderate intensity physical activity per week. So huge improvements. Also improvements in participation in sport, mental well-being and perceptions of health. And we've reduced sitting time and inactivity, and in our case studies we've shown significant weight loss and improvements in diabetes, such as in this case study to the right here, who is someone called Mike. We've helped to develop legacy services, and one of which is the Active Watford and Three Rivers service, which is now funded by Watford Football Club and has reached over 700 individuals. And again, there's evidence that it has reduced inactivity and improved satisfaction with life, happiness and anxiety. And the service lead there has said using these strategies during consultations with clients and through our behaviour change booklet, which is based on our research, has helped to deliver a service that meets the needs of our clients and has had a significant positive impact on service delivery and client engagement. And clients have told us that it's changed their life. They feel better, fitter, and they've lost weight. The cardiology department at Bedfordshire Hospital, who receive over 500 patients annually, has also changed their clinical practice, and they encourage patients to reduce and break up their sedentary time. We've seen conferences use stretch and screen breaks based on our research, and the Police Triforce annual Wellbeing Conference had a whole standing portion at their day-long event. Bedfordshire Police continue to use our strategies where we put QR codes across headquarters where people would get up and scan them, which they found has benefited occupational health. And the University of Bedfordshire now embrace an active campus where across our estates we have sit-stand desks, treadmill desks, and staff embrace standing classrooms and standing meetings. We've widened that societal awareness. I've spoken at the main auditorium at Cheltenham Science Festival, in the House of Lords and the House of Commons, and at all party parliamentary groups to really get people involved in understanding and being aware of the importance of these issues. We've featured on the BBC One Truth About Improving Your Mental Health with Tanya Byron, and I was teaching Tanya Byron how to do a combi behavioural diagnosis on this flip chart, and we saw an increase in referrals to the Active Hearts and the Active Watford and Three Rivers programmes following that broadcast. I'm an expert advisor for Sport England and for the Richmond Group of Charities, and helping to support them on the We Are Undefeatable campaign, which promotes physical activity for long-term conditions. And we've had a significant amount of media interest, highlighting the importance of psychology and behaviour to support long-term conditions. So our future steps, we will continue to work in the area of physical activity for the benefit of long-term conditions, and we've recently recruited another PhD student who's going to support us in this, Phoebe, who I know is on the call, and we will work with our University of Bedfordshire Community Exercise Clinic to support people in the local area along with national programmes. Just want to thank all of our ISPAR funders. This research wouldn't be able to happen without this sort of funding. And a special thanks to our research collaborators. Haven't been able to name them all, but in particular Dan and Lindsay, and our PhD graduates whose many of the work I've just presented on is included there. Dr. Marsha Braley, Dr. Samson Ogio, and Dr. Neil Howlett. Okay, so I'll leave it there. Thank you for listening.
Thank you, Angel. Another brilliant presentation. So floor is open to questions. I think we're slightly over time, 7 minutes over at the moment, so we'll just have one question.
I'm going to switch it over for a second because I can't see anyone.
Either pop it in the chat or speak. Okay, I'm sure Angel will answer any questions afterwards. I can ask a question if you want, or do you want to move on?
It's up to you. Well, shall we get people to pop questions in the chat if they have them?
Yeah.
And then we can have a short break, and then we can resume, just so we give people an opportunity to move. Yeah. Otherwise, we should practice what we preach, shouldn't we? Okay, so, I think if we come back at 8 minutes past, that will get us back on track.
Mm-hmm. Okay. Yeah, we've got a little bit of leg room in the next session.
We have. Yeah, we have. All right,
okay,
everyone.
So 5 minute break.
See you at 8 minutes past. So we now have two segments, which is going to showcase our ISPAR postgraduate research students' research. And first up is Abby Moffat, who is going to talk about using behavioural science within local authority public health. Abby is one of our first year PGR students and is going to share her work. So Abby, over to you.
Perfect, thank you, Angel. Hi everyone, I'm Abby Moffat, and today I'll be talking about a study that I've recently undertaken as part of my PhD, which explores the use of behavioural science in local authority public health. So to start then, I just want to give a definition of what actually is behavioural science. So it's an umbrella term that encompasses a range of disciplines such as economics, sociology and psychology. And today I'll be focusing on the discipline of psychology, which is the scientific study of the human mind and its functions and how these functions influence behaviour and psychological processes. But psychology has many branches, and my specific area is in health psychology, which aims to study the psychological processes and behaviours that influence health and illness in the hope of promoting health and preventing illness and disease. And one of the key areas within health psychology research and expertise is behaviour and behaviour change. And because of this, it's often referred to interchangeably as behavioural science, particularly within public health settings. So within behavioural science and specifically health psychology, there is a wealth of resources that have been produced to support and guide public health practice. And these resources have been utilised by organisations such as NICE, who've drawn on behavioural science theory and models to produce a set of guiding principles for behaviour change approaches. And more recently in 2018, Public Health England and colleagues produced a document outlining how behavioural and social sciences could be used to enhance and improve population health. And this led to the development of PHE's Achieving Behaviour Change Guide, which provides a step-by-step support for intervention development at both a local and national level. However, in spite of this, there is often challenges around implementing these resources in practice. And currently, we don't have any comprehensive scientific evidence to identify what factors may be contributing towards this. So as a result, the current study sought to further explore this in the hope of being able to support public health to fully benefit from behavioural science insights. So in consideration of this then, the current research had three main aims. It wanted to gather an understanding of how behavioural science is currently used within local authority public health. It wanted to look at and understand what factors may influence this use and how the integration of behavioural science and specifically health psychology could be supported within local authority public health. So to answer these questions, my research team and I created a 13-question interview schedule exploring these areas. I interviewed 15 members of a local authority public health team and their close colleagues. And within this, participants were sampled based on their job roles to try and ensure that individuals from all levels of the organisation were represented. And once the interviews were complete, they were then analysed using thematic analysis to identify themes. So from this research then, 8 themes were identified. I'm now going to go through each of them in more detail and discuss them a little further. So theme 1 then is the awareness of need, and this theme highlights that there are some public health employees who don't see the need for using behavioural science in their work and may not believe it could actually improve what they're currently doing. This is demonstrated by Charlie's quote that says, "I think it is that many people don't see the value of it. They think that the way to do things is the way they've been doing them up until now." It was also felt that due to the evaluation techniques currently used, there actually isn't always the opportunity to demonstrate that outcomes have the potential to be improved through incorporating behavioural science. And for those that may not believe there is a need for it, actually being told that they need to change their current practice can lead to feelings of being criticised. So the second theme then, generating buy-in, outlines that there are a range of beliefs around behavioural science, which may mean that some individuals are a little bit wary about using it. So for example, some people fear that it may be seen as manipulative. However, there was a strong agreement that actually to encourage buy-in across the board, it has to be driven from the top. Which is outlined here by Lisa, who says, so getting people higher up the organisation to be promoting it and talking about the value of it. There's nothing like a leader or a politician talking about something to make other people want to take part. So leading on then from this need for buy-in, The third theme, named Collaborative Whole Systems Approach, highlights that public health teams don't work in isolation, and therefore collaborative working is essential if we want to truly embed behavioural science within public health systems. And Katie demonstrates this here by saying, I mean, everything we do in public health is, well, not everything, but so much is so reliant on partnerships and influencing people. However, it came to light that collaborative working isn't always easy, and this has been a long-standing challenge for the public health team. And there are many reasons given for this, such as conflicting priorities, strained relationships, and often a lack of commitment from partners. So the fourth theme, organisational culture and political landscape, outlines how the culture of the council and subsequently the work that it undertakes is heavily influenced by politics. And here Faye sums this point up by saying, I suspect if we had a different political leadership, we would see a different reaction and different responses. So it's all kind of intertwined. I mean, public health is politics, isn't it? And participants felt that actually these political needs impacted the ability to implement new things such as behavioural science. And this was thought to be due to increased risk aversion that they felt was directly linked to the political pressures being placed on the local authority. And it was suggested that there's a need for a cultural shift, but this isn't just at a local authority level, but actually nationally. So the fifth theme, automaticity of use, demonstrates that there seems to be a divide. So we had people that believe that behavioural science is regularly being used in everyday practice. And then we had those then that, although they may think about it, were actually really implementing it. And there seemed to be intention to use it, but quickly people fell back into old habits and routines. And as Katie says here, when you get people in a room and you help facilitate their thinking, they're like, oh, and what about this and what about that? But then when you get back to the office, again, the normal, however it's been done before, comes in and all of that goes out the window. However, participants did express a desire to actually get to a point where using behavioural science just becomes second nature. Oh my gosh, hang on, sorry. Don't know what's happened there. Sorry, one moment. Okay. So then the sixth theme, translational gap from theory to practice, outlines how the challenges in implementation may actually be due to the presence of a theory practice gap. And although previous training resources have been provided, this has actually often been seen as too academic, and this makes it difficult to understand it, but also to actually apply it in practice. So there's a need to bridge this gap by making behavioural science more accessible. And Philippa sums this theme up well here by saying, I think that for all of us to understand through case studies and proper examples, we can easily embed it, but there is a huge knowledge gap. Within theme 7, a need for investment in behavioural science was discussed, and participants spoke about wanting ongoing support from an expert, with one participant stating, what would be really nice is ongoing support where people have got access to someone who can just kind of go, yeah, I think you're on the right track. And there was a preference for this support to be in-house, as this person would then understand that the organisation, and they'd understand the parameters actually within which that team are working. And participants felt that having the support in hand would eventually change their practice. So alongside ongoing support, our last theme, lack of time, was a key issue. Participants felt that they're just too busy to try and implement something new, which isn't helped by a perceived pressure to get things done quickly when often actually more time is required. And this time pressure had further knock-on effects. So for example, Megan says here, when we're all so busy and you've got loads of different plates spinning and you're trying to remember everything, you just want to get the campaign done. You haven't necessarily got the time to sit down and think, oh, this is a good campaign, but how can I make it better by adding in behavioural science? And actually participants felt that because of this, behavioural science often becomes merely a tick box exercise that they have to do. However, many people felt that actually being given protected time could help to overcome this. So overall then, the study identified a range of key influences on the use of behavioural science in local authority public health, and it provides further support for the notion that actually, in spite of this wealth of knowledge that behavioural science has produced, there are still difficulties with implementing this into everyday practice. And actually recognising and addressing these barriers could be said to be more important than ever. And this isn't only because of the challenges local authorities are currently facing in terms of COVID-19, but also because of the way that healthcare is set to develop. So the NHS long-term plan has set out a 10-year agenda which focuses very heavily on preventative health programmes to tackle behaviour and psychosocial factors contributing towards the development of illness and disease. And for this reason, it's really, really important that we find ways to support public health teams to incorporate behavioural science into their practice so that they can optimise outcomes. So moving forward, we need further research is required to really explore how we can actually do this successfully. So thank you so much for listening. I know we do have a segment for questions at the end, but if there's anything, any burning questions, please stick them in the chat and I'll be happy to answer them. Thanks very much.
Thank you, Abby. I'm sure if we were in our Gateway building right now, you'd have a round of applause. That was great. Thank you very much. So absolutely, as Abby said, we'll have a Q&A at the end of these 4 presentations. So do put questions in the chat for Abby. Thank you, Abby. Well done. That was great. So next up is another of our PhD students, Fanny Lapie, who hopefully will be putting up her slides in a second. Fanny is in her 3rd year of her PhD now, and is going to be talking to us about factors that facilitate or hinder whole system integrated care for obesity and mental health. So Fanny, if you want to share your slides.
Hi, Angel. Hello, everyone. So can you see my screen?
Yes, just pop it on presentation. Perfect, Fanny.
Is that okay?
Absolutely, it's okay.
Lovely.
Okay,
Thanks.
so over to you.
So today I'm going to present my scoping review, which is one of the studies of my PhD. Which is called Barriers and Facilitators of the Implementation of Whole System Integrated Care for Obesity and Mental Health, taking a whole system approach. So integrated care represents a fundamental shift in the way the healthcare system is organized. It's all about giving people the support they need, and it removes divisions between healthcare professionals and organizations. So whole system approach is called to respond to the complexity of integrated care. It connects stakeholders and communities together to develop a shared understanding of the challenge and to bring sustainable and long-term systems change. So obesity and mental health are 2 major health issues worldwide, and 2 of the public health priorities according to the latest NHS long-term plan. Obesity is a complex health issue. The Foresight report highlights the social and biological complexity in managing obesity. As you can see on the left, the obesity system map is created by a large number of cultural, environmental, and psychological factors. Therefore, taking a whole system approach would be beneficial to an integrated initiative to tackle obesity. So the aim of this review is to collect and synthesize evidence on barriers and facilitators of the implementation of whole system integrated interventions for obesity and mental health, and the impact on those interventions of patients' physiological and psychological outcomes. The following research questions will guide this review. What are the barriers and facilitators of the implementation of whole system integrated intervention for obesity and mental health? And what is the impact of whole system integrated interventions on the patient's outcomes? So a very broad search strategy was employed. We consider qualitative, quantitative, and mixed method studies focus on any population. The interventions of interest are initiatives to tackle obesity and improve mental health in an integrated care setting, taking a whole system approach. More details such as search strategy, the developed definitions, and inclusion and exclusion criteria are available on the recently published report protocol. So almost 27,000 records were screened. 20 articles are included. From those, 12 studies report barriers and facilitators of the implementation, and 6 report outcomes. So let's have a look at the findings. All, of course, are equally important. Most facilitators to the implementation process were reported at the organizational level, including the development of local partnerships and networks, human resources, recognition of cultural variation, structured multidisciplinary approach, and community awareness and engagement. Also, we found facilitators of functional integration, such as resources, such as the funding and the communication, and for professional integration, such as the workforce development, staff training. Moreover, this study found that there are interrelationships in elements which affect different types of integration. For example, depending the available funding can influence human resources and the recruitment of a central care coordinator, and the availability of staff training, the workforce development. In this review, the identified barriers, the identified facilitators answered to the question what is needed, and the identified barriers answered what doesn't work. Some studies identified the stable funding as a facilitator, while financial constraints have been identified as barrier in another studies. In terms of the outcomes, 4 studies reported positive impact. I'm really sorry, of whole system interventions in children's weight. And 2 studies reported improvement in psychological distress in young people after the intervention. Overall, the findings of this review indicate the answers to the questions what is needed often reflect the answers to the question what doesn't work. It also provides qualitative and quantitative evidence on factors influencing the implementation of whole system integrated interventions and their impact on childhood obesity and mental health. However, the majority are focused on childhood obesity. Only 1 study focuses on adults. Also, there is a variety of descriptive language in terms of the definition of a whole system integrated intervention. More research is required for the development of agreed definitions of whole system integrated care, what whole system integrated interventions are. Thank you very much. Any questions?
Annie, well done again. If we were Ring the Gateway, we'd be clapping you with a loud applause. That was fantastic. Well done. Okay, so we'll ask people to pop questions in the chat. So if you do have questions for Fanny, please put them in the chat, and then we'll bring them all together in our Q&A session shortly. We've got 2 more presentations now. But okay. Fanny, well done. Very important piece of work there. And lots of praise from Yanis in the chat. Thanks, Yanis.
Thank you.
So Jamie is up next. Jamie, if I could ask you to share your screen, please. Well done. Okay, that looks great. So up next is Jamie Whitehall. He is one of our first year PhD students and a part-time student. And he's going to do a different type of presentation. We call them 3-minute theses. We should be picking up on our time now, Jamie, no pressure to you. But Jamie's going to give you a bit of an overview of where his thesis is going and what he's done so far. So Jamie, over to you.
Perfect, thank you. So I'm going to talk about my PhD in general, so looking at obesity-related behaviour change training, or also known as ORBIT, for health professionals. So really, to start with the rationale for obesity. So obesity is a complex and multifactorial issue. It's also rising in global prevalence, as you can see from the figure on the right there, continually rising across the years since 1993, as the data suggests. Obesity is also an increased risk towards impaired daily life, and also an increased risk towards COVID-19 and subsequent hospitalisation and mortality because of this. And obesity also increases the risk of numerous non-communicable diseases, reduced health and premature mortality. As you can see at the bottom right, 41% of individuals were classified as overweight, but not living with obesity, and that's for males. And then females, the same figure was 30%. And then looking at males who were living with obesity, including morbid obesity, 26% were males and 29% were females, which was from the NHS Digital in 2020. So focusing in then on the actual problem that we're looking at, really we're looking at weight stigma. So weight stigma causes an increase in missed patient appointments, an increase in weight gain, internalized stigma. So the actual stigma is then internalized, so the people are representing that towards themselves, an increase in association with mortality, and then also a decrease in psychological health and overall patient incomes. So from the statistics here on the right, which was a study completed by the Obesity Action Coalition in 2019, 31% of nurses would prefer not to treat patients that are living with obesity. 24% of nurses agreed that patients with obesity actually repulsed them, and 12% of nurses would prefer not to touch patients living with obesity. So as you can tell, these statistics are really significant and something which drastically does need to be changed. From the perspectives of individuals living with obesity, 69% of patients reported that physicians are a source of weight bias. 52% of patients reported that they've been stigmatized on multiple visits. So this is something that isn't just happening as a one-off occasion, this is numerous times. And then physicians are also the second highest source of weight bias. So again, the statistics are really showing. So the aims and objectives really are sort of, the overall aim is to assess and improve the capability, the opportunity and the motivation of health professionals in order to allow them to effectively communicate and raise the topic of weight with patients, but to then complete a brief COM-B assessment with their patients, providing opportunistic support and advice, and then going that one step further to provide them with further support by referring and signposting them to the appropriate services. And this is all completed using the COM-B and the behaviour change wheel. So generally then the proposed methods to sort of carry this out, we're starting off with completing a systematic review, then moving on and doing 3 separate lots of interviews. So the first one being with health professionals, then looking at students and trainees, and then looking at patients. So we want to gather information from all aspects in order to create this. The idea then is to move on to actually look at observations of current practices. So what are patients' perceptions and actually what's happening within practice at the moment. And then also completing health professional surveys to get health professionals' views on the current training and what needs to be changed. This all comes together ideally to form the ORBIT, the Obesity Related Behaviour Change Training Programme. And we're looking at running a feasibility trial to conclude the studies. So the anticipated implications from this then, firstly, of course, there's going to be hopefully an improvement in training on obesity and behaviour change, which is available for health professionals. This will then lead to improving health professionals' knowledge, capabilities, and their sort of thoughts around obesity and behaviour change, and leading to a decrease in weight stigma towards individuals living with obesity, particularly from the health professionals. All of this then comes together to form an improvement in patient outcomes that are associated with obesity. So the current progress so far, we're currently started with the systematic review. It's been published up onto Prospero at the moment in terms of registered there. I'm working part-time as a PhD candidate and also working as a social prescribing link worker within primary care. So sort of seeing these things firsthand. I'm also conducting another systematic review, which is looking at barriers and facilitators to remote engagement with weight management interventions, working with the Open University and the University of Bedfordshire. And I've previously worked in Tier 2 adult and family weight management service as well. So the next steps moving forward with the initial systematic review. So looking at the population, we're looking at health professionals that are aged 18 and above and that have received obesity-related behaviour change training previously. The intervention are studies that are involving obesity-related behaviour change training, making sure that it includes and describes the use of behaviour change theory, and it can be delivered directly, so face-to-face or indirectly through sort of digital media or online. It can have with or without a comparison group, and the outcomes that we're focusing on are sort of three separate parts. So the first one is actually looking at the training outcomes. So looking at individuals' knowledge, skills, intentions, and their perspectives. Then looking at the physiological patient outcomes. So looking at things like BMI, blood pressure, waist circumference, and cardiometabolic markers. But then also going that step further to look at psychological patient outcomes. So looking at individuals' perception of weight stigma, their physical activity, and their eating behaviours. And that's where we're at with the systematic review. So watch this space for more research to come. And thank you for listening.
Well done, Jamie. Well done. Great presentation again. Thank you very much. And I can see you've already got some questions in the chat, so we will hold those over just till after Jane's presentation. But very well done again. Again, another really important piece of research, although I'm a bit biased today with all this research, but you did a great job. Well done. Okay, so next up in this session, and the last speaker of this session is Jane Williams. And while Jane gets her slides up, I'll do a brief intro.
I can't because you've not made me a host.
Okay, because you had to dip out. So let me just fix that. Hold on a second. Oh goodness, where are you? Hang on. Oh, there you are. There you go, Jane.
Thank you.
No problemo. Okay, so Jane is the last speaker in this section, and Jane is now one of our PhD graduates, so I should introduce her as Dr. Jane Williams. Jane received her PhD this year, and is going to talk to you about whether physical activity support, hang on, let me rephrase. It's her systematic review on can physical activity support grief outcomes in individuals who've been bereaved. So Jane, over to you.
Thank you very much. Can you see my slides? Just want to check.
Yeah, they're absolutely fine.
Well, good morning and welcome to my talk. My name is Jane Williams and I'm going to talk about my systematic review from my thesis. So firstly, I think it's important to know why this research is needed and why it's important. So in 2018, there was over 616,000 registered deaths within the UK. And when this happens, you'll experience a bereavement, and bereavement is a common experience following death, and it is experienced by the majority of individuals at some point in their life. And the term bereavement is often used interchangeably with grief and mourning, but yet they differ in meaning slightly. So bereavement refers to being in a state of loss as a result of the death of a significant relationship. Mourning is an expression of grief, and grief is the complex biopsychosocial response and reaction to bereavement. And anyone who has experienced a natural, sudden or traumatic death should be able to access support if they need it or they want it. And the UK has wide support groups across the UK offering counselling, individual sessions, group sessions, activity days and weekend retreats. And next, I think it's important to consider what these biopsychosocial factors experienced during grief, normally called grief outcomes, what actually are they? So I've been able to split grief outcomes into affective, which will cover things like anger, depression, anxiety, and guilt. Then we have behavioural grief outcomes, which cover things like aggression, isolation, substance use, and suicide. And then we have cognitive grief outcomes, which cover resilience, suicide ideation, concentration, and well-being. Now, however, it's important to note that many of these grief outcomes are also considered mental health aspects, and one way to support mental health is by using physical activity, which there is an abundance of research in. So physical activity can help to decrease anxiety and depression, which is effective. It can help to control aggression and decrease isolation, which is behavioural. And it can also help to increase self-esteem and improve quality of life, which is cognitive. And as many of these grief outcomes, such as depression, aggression, lower self-esteem, are also mental health concerns without the experience of bereavement, it's then plausible to suggest that options to improve mental health, such as physical activity, would be able to support grief outcomes, which is where this aim of the research which I've conducted has come from. So the aim of my systematic review was to identify studies which have investigated the role of physical activity following bereavement, with research questions: can physical activity benefit grief outcomes? If so, what grief outcomes are they, and what type of physical activity would be beneficial? So when designing this review, we started out with a big scoping review, as the main focus originally was just on parental bereavement. However, after this scoping review, we realised there was very limited studies, so we opened it up to make it quite broad. So the inclusion criteria for my systematic review was: the study had to include a personal bereavement, it had to use physical activity to support grief outcomes, and grief outcomes must have been measured. So with that inclusion criteria, we started to create our search terms, and we used PICOs. So with the population, we wanted to have search terms that included a range of deaths. So as you can see from the slides here, we've got things like general bereavement and grief, but we've also had parental death, spousal death, sibling death, as we want to cover all types. We also have the intervention. So the intervention had to include physical activity, so exercise, sport, outdoor physical activity, adventure therapy. We also have no comparison, and the outcomes had to address some grief outcomes measured. So as you can see here, there's a long list of outcomes going from anxiety, depression, to emotional eating and insomnia. And we wanted to leave this as open as possible so that we could encompass all of the research that is out there. We also used the mixed methods appraisal tool, the MMAT, to appraise the quality of these studies. So what did we find? Well, during the initial search, we found 1,545 titles and abstracts with 2 additional sources. When we whittled that down to remove the duplicates, we had 1,299, which we screened the titles and abstracts, and then we excluded 1,248, which left me with 51 full texts to read through. And from this, we excluded 26 for multiple reasons that didn't actually include physical activity. It was focused on physical functioning. There was no relationship between physical activity and bereavement. And that meant we had 25 eligible studies to include within the systematic review. And from those 25 eligible studies, we pulled out the study and participant characteristics, grief outcomes, relationship and length of bereavement, and the types of physical activities that were used. And these are the details of the 25 included studies. So as you can see, we have 8 different types of bereavement relationships, which are just across the top here. So we've got spousal death, parental, patient, multiple, fetal, later life, general or caregiver deaths. And we have 14 quantitative, 9 qualitative and 2 mixed method studies. There's 11 different countries, which the data encompasses, with over 157,000 participants included. And as you can see, there's quite a lot of similar authors. So for example, we have McLachley et al. In 2009 who completed an intervention, and then in 2012 followed that up with the same participant pool and did interviews. And similarly, Brewer and Sparks in 2011 used the same participant pool to complete 2 studies. So what kind of physical activities were used? Well, there were 22 different physical activities that were noted within the research, and these range from martial arts, rugby, walking, yoga, hiking, canoeing, donjon, and football. There was lots of different activities mentioned. However, 13 studies did not mention which physical activities were used, and this needs to be mentioned as then we know what activities are beneficial to support the grief outcomes. And there was a total of 26 grief outcomes mentioned, with depression being the most commonly mentioned in 12 studies, followed by anxiety and stress. So what did they find? So these included studies found that physical activity helps to increase life satisfaction, increase self-esteem, increase health, increase their well-being, help to decrease depression and fatigue, both mentally and physically, help to decrease loneliness, PTSD and stress. And physical activity was able to do all of those things by creating different mechanisms, such as creating an emotional outlet, being able to provide an escapism, by creating a sense of freedom within physical activity and being able to create friendships. It also helped to develop some coping mechanisms and create some family cohesion and some social support. So what we've found from this is this review suggests that physical activity may be beneficial to support individuals following a bereavement. As you can see, physical activity covered 26 different grief outcomes, so physical activity can benefit a variety of grief outcomes, and a variety of different physical activities can be used to support grief outcomes and may be beneficial. And I just want to kind of leave this note here that people tend to believe that grief shrinks over time. And actually what happens is that we grow around this grief, and that physical activity may be able to help support this growth as you grow around your grief. And just going to highlight the next steps. So what from this review we found is we need more experimental research. We need to be able to put interventions in place to find out what physical activities are more beneficial and if it's actually beneficial to support different grief outcomes. And bereavement organisations need to provide physical activity to help support grief outcomes and bereavement in young people and anyone. So thank you very much for listening. I just want to thank my research team and the university, and my systematic review has been published, so please do go read it, and thank you.
Well, fantastic, Jane, great presentation, and again, if we were in the room, everyone would be applauding. Great stuff. So thank you to everyone for listening. We'll now open out for a Q&A session. And I know that there's a few questions in the chat. So if our speakers want to come back on, put their videos back on. So I feel like I'm going slightly backwards on them. I can see there's a question from Laura, and I know Laura might have had to run, but someone in her team is in there, around using the 5 A's of obesity management. So Jamie, can I bring you in to just answer that question, please?
Definitely, yeah. So the 5 A's is something which I sort of currently advocate within practice anyway. And it's something that I'll sort of definitely be drawing upon throughout the whole of the research that I'm planning to do. It is actually really good for sort of initial training for health professionals to actually raise the topic of weight initially.
And can you remind us what those 5 A's are?
Yeah, so the sort of 5 A's also come with the 3 M's as well. So it's mainly around actually raising the topic of weight. So initially it's about asking permission to actually, if it's something that the people actually want to talk about, if they're ready to talk about it at that moment in time. And then it's about almost working with them to create action planning and to sort of further develop and actually assessing what they're doing as well. So almost linking into that COMBI analysis within the assessment that you're doing with the patients.
Brilliant, thanks Jamie, fantastic. And Abby, I see that there was a question for you in the chat about engaging policymakers, not policymakers, well, people on the ground in terms of public health in using behavioural science. So do you want to elaborate a little bit on that, on the answer to that question?
Yeah, I just in the reply I just said that my personal experience has been that a lot of people are open to it in public health and they understand, or they want to be able to use it, but the barriers that that I mentioned are getting in the way of that actually being able to happen. And I think some of the things, well, hopefully we will discover what the ways of overcoming that are as we go along, but I think it needs to be making things accessible so that people can actually use them in practice, and stopping things being as academic, perhaps, when we're trying to have that impact outside of academia, and demonstrating where it's worked and giving some examples to show policymakers and to show practitioners that actually this stuff can improve outcomes if you're able to integrate behavioural science into your work.
Yeah, and I think you know, we hear it quite a lot. People want to use behavioural science to optimise their work and their outcomes, but sometimes there's not always either the capability because they don't know how, or the opportunity because the system doesn't allow them to in some way, or there's not that social culture there, or the motivation because they think, oh God, it's a bit too much like hard work, or you know, your habit of just doing what you always do gets in the way. So I think going forward, you know, using that behaviour change approach to help embed behaviour change approaches, you know, will really kind of open our eyes on that. So thank you, Abby, thank you. And Jane, a question in the chat for you. Can you tell us, well, first of all, a comment. So Yanis has commented that it's surprising that so many interventions could be published without the detail of what the intervention actually was. So your reference to them not saying what the physical activity was, which I think, you know, we all acknowledge as a limitation. But Julia then asks, can you tell us about the types of physical activity you might expect to be the most beneficial? And she says outdoor versus indoor. So your thoughts on those 2 points, please.
Yeah, so the first point, there's actually, in the systematic review as well, there's actually quite a lot of studies that didn't define grief outcomes, it just blanketed it as grief. So it's also important to note that that wasn't signposted as well, and that wasn't carried out to give that detail, which doesn't help. But it's important to note as well. And in terms of outdoor, indoors, different types of physical activity, there's no research at the moment to say one is better than the other, because the review gave such a wide breadth of physical activities, both outdoor and indoors. But there is research out there to say that outdoors actually could be more beneficial with the green space. And actually a couple of the, one of my other PhD studies was observing Bereavement organisation which did outdoor physical activities, and the children that took part and that preferred to be outdoors when they were talking about their grief and just being outdoors in general, they found to be more beneficial. And works by Brewer and Sparks also noted that as well, by saying how they find it easier to have conversations because you don't have to look at someone in the eye, your eyes can kind of wander. So I would sway to more outdoors to be indoors, but again I think it could be a completely independent personal thing depending on your interests and the type of person you are.
Yeah, thanks, Jane. Jane, you just want to elaborate briefly on that and the Eclipse programme that's being planned?
Yeah, so we've from my PhD and all the research that's gone into it, we've developed an Eclipse intervention. So we'll be using a walking group to see if being outdoors and walking will be able to benefit the grief outcomes. So trying to put in some of the suggestions from previous studies I've done, so questionnaires and interviews, and taking on the systematic review recommendations to see if walking is beneficial, to start to kind of narrow down which activities, indoor, outdoors, and different activities.
Brilliant, thanks, Jane. And one more question before we head into a break. There's a question from Irina, who first says great presentations. I agree, well done everybody. But then asks about whether dance for health has been considered as a type of physical activity to improve aspects of physical and mental health, and highlights their studies for Parkinson's and benefits highlighted in some publications. So absolutely, and we actually have another of our PhD students on the call. She may not be she may not be able to speak, but I don't know, Sarah, if you're able to come in at all. No worries if you can't, because I know some people are joining via phones or things that don't have media, but if you are, do pop yourself off of mute and video to say hello. But we do have a PhD student who's recently joined us who is looking at exactly that, Irina. So looking at physical activity, looking at dance for benefit of long-term conditions. Oh yes, so she can't come off mute. Too much information, Sarah. Fitting flooring, there we go. Yeah, so that's definitely an area that our institute is looking at taking forward. And we actually have an MSc in dance science, which is linked into our behavioural science and public health and health psychology units. So it's something that we do have quite a great interest in. So Irina, watch this space. Hopefully we'll be able to give you some more information on that going forward. Absolutely, we'll connect. Brilliant. Okay, so I'm going to head us into a break now. So we'll have a short break and we'll reconvene at 12 o'clock midday to continue our presentations. So thank you all for listening and for your questions so far, and we look forward to seeing you in 7 minutes time. Please do get up, stretch, make a cup of tea, and we'll see you back shortly. hopefully you've moved or at least broke up your sitting time briefly in that short break. I'm going to hand you over to Julia Frewer now, who is one of our senior lecturers and the deputy lead for this particular research centre within the Institute for Sport and Physical Activity Research. So Julia's going to chair this afternoon session. So Julia, over to you.
Thank you, Angel. So this session is going to run in a similar way to the last section, with mainly our research students presenting, and then we're going to round off with our alumni keynote, Ben Mailer, for the final presentation. So our first speaker is Dora. Dora, do you want to get your slides up? I'm not sure if Dora's back with us yet.
I am, just it says that I can't share my screen.
Oh, okay.
Let me try and fix that.
Okay, Angel will sort that out today. So Dora is another one of our research students, and she's going to be presenting her systematic review, which focuses on positive psychology interventions to improve the health and well-being of police staff. And
yeah, here says the same, I'm afraid. The host disabled sharing. Ah, it's good now.
Should be a co-host.
yeah,
Can you see my screen?
it's just coming up now. So if you just enlarge it so it's on full screen mode. And
I can see it.
yeah, perfect. So when you're ready, Dora.
Okay, all right. So hello everyone. I am going to talk to you about the use and effectiveness of positive psychology interventions, also called PPIs, to improve the health. And I don't know what's going on. Ah, everything jumps up. Yeah, so improve the health and well-being of police staff. So this was a systematic review. So just a quick introduction of what PPIs are. So these are interventions that aim to increase the positive thoughts, emotions, and cognitions in people's everyday lives to help them cope better with negative events, moods, stresses of everyday life. This can take form in a gratitude diary or practicing mindfulness or using positive mantras, but there are many other examples that I could bring up here. So the aim of this review was, on the one hand, to see what type of positive psychology interventions have been used to improve the health and well-being of the police staff, but also whether this can actually effectively improve health behavior, physical health, or psychological well-being for the police staff. Inclusion and exclusion criteria were, so the population that we looked at was police officers or police staff. Now, police staff here means that non-operational staff. Any studies that worked with any other kinds of populations that is not police were obviously excluded. Interventions looked at positive psychology interventions either with no treatment, waitlist control groups, or no control group at all. However, all those studies would have been excluded that use conjunction therapy. So, for example, pharmacological interventions with PPIs, or a pharmacological intervention with any type of psychological therapy as a comparison. When we look at outcomes, we looked at three different, let's say, groups of outcomes. So one is psychological well-being, anxiety, depression, and stress. Or physical well-being, such as cardiovascular or musculoskeletal health, BMI, cholesterol levels, blood pressure, glucose levels, or behavioral. So it could have been physical activity, sitting times, diet. So it includes vegetable and fruit consumption or breakfast consumption, for instance, smoking, alcohol use, drug use, and sleep. Now, any study that would have not measured any of the, at least one of these outcomes would have been excluded. So in terms of study characteristics, we included 12 studies in the end. So it gave us 1,100 operational and non-operational police staff. members with a mean age of 36 years, and they were quite experienced police officers, to be honest, because if you see that it's between 10 and 20 years in survey, so these are quite experienced people. However, 2 studies did not share demographics, so that might not be the end of it. Interventions wise, there were the majority was mindfulness-based resilience training. Some of them use progressive relaxation with guided imagery and some role play. So these role plays sometimes included car chase or house search, things like that. Expressive writing, which is pretty much like diaries, and Pythagorean self-awareness. I'm happy to explain later if anyone is interested what that is. The duration of these lasted anywhere between 8 to 16 weeks. And the majority of them used no treatment or waitlist control, but 2 studies had no control group at all. So results-wise, you will come to see that there were some conflicting evidences there. So as mindfulness interventions were the vast majority of these, in the review of the studies that they used, so they actually measured the biggest variety of psychological outcomes. But in some studies, for example, in terms of organizational and operational stress, although it shows reductions, but some studies actually show no significant improvements at all. I included those references in the bottom if anyone is interested. Only 1 study measured occupational stress, which was non-significant. And similarly for anxiety and depression. So most of the studies actually found significant reductions, but 2 studies did not. I mean, one of them did not find it in anxiety and depression, and one of them didn't find any significant improvements in depression. Negative effect, as you can see, was quite successful across the board. So most studies actually found some significant reductions in that. 1 study actually measured general health and health complaints as well. Now, it's important to mention that these were self-reported ones. They did not use objective measures or GP records to actually say that, yeah, this is significant. And only 1 measured alcohol consumption, and it was unfortunately not significant in terms of reduction. Role plays and scenario-based interventions. Now, it's interesting because there were 2 of them. So one of the studies actually measured depression and negative affect, and it showed significant reductions, but 1 study only measured anxiety, which shown statistically significant reductions. In terms of expressive writing, that seemed to be the most robust when it comes to anxiety and perceived stress. And depression was unfortunately not really significant in this one. And the Pythagorean self-awareness intervention, again, did not show significant reductions in terms of organizational operational polystress, but it did in negative affect. So in conclusion, it is quite promising. So there are some really good things there. However, the evidence is not robust. And one reason might be because most of the studies actually use quite small sample sizes. So in the future, definitely larger sample sizes or RCTs with larger sample sizes are definitely needed. And also it's very important to account for some confounding variables. So I did not mention this in my slides, but there were a few studies where they anyway had a small sample size, but they lost quite a few people either prior to randomization or after randomization because of scheduling problems or because police officers found it too time consuming to participate in these interventions. And also there would be really good to see more positive psychology interventions, so bigger variety rather than just mostly mindfulness and relaxation based resilience training. But that probably would require a better promotion or some form of promotion of positive psychology interventions in the police force and in police related research. Thank you very much for listening. I hope it was informative.
Thank you very much, Dora. That was a really interesting presentation. And as we did in the last session, we'll save questions for the end. And but feel free to add them to the chat if you have any questions now. Right, so we'll move on now. We're going to move slightly into a different discipline. We're going to move from health psychology and behaviour change more towards physiology and metabolism. And we're going to start with a student that actually I supervise externally, who's based at Loughborough University, and she is called Sahar Afif and should be with us now. So if you wanted to share your slides, Sahar, with us, you're able to do that. You still with us, Sahar?
Hello?
Hello.
Yeah, I can't share my slides because other participants is sharing.
Okay, Angel, are you happy to make Sahara co-host?
Yeah, now I can share my slides.
Okay, thank you. Perfect. So Sahara's going to be presenting on a study she's completed as part of her PhD, which focuses on how moderate and high intensity exercise bouts might be able to improve glucose responses in free living conditions in healthy adolescents. So over to you, Sahar.
Okay, thank you, Julia. Hello, everyone. I'm Sahar Afif, a doctoral researcher at Loughborough University, and I'm going to present some of my PhD work that focused on postprandial glycemic responses to different exercise intensity bouts performed in a school setting in healthy adolescents. So postprandial glycemia contributes to the development of chronic diseases such as type 2 diabetes and cardiovascular disease by promoting oxidative stress, inflammation, and endothelial dysfunction. Glycemic variability, which reflects blood glucose fluctuation throughout the day, including periods of hypo and hyperglycemia, can also contribute to endothelial damage by increasing oxidative stress than consistent hyperglycemia in normal and diabetic adults. So it is very well known that physical activity improves insulin sensitivity and increases glucose uptake in the exercising muscles. Therefore, it can moderate postprandial glycemia and may reduce glycemic variability. So to give a brief summary of the current literature on acute effect of exercise on postprandial glycemia in healthy adolescents, we can see from laboratory-based research a reduced glycemic responses to oral glucose tolerance test after an acute bout of exercise. However, recent studies have shown no glycemic differences in response to more ecologically valid meals after a bout of exercise. The acute effect of exercise on postprandial glycemia have shown to last up to 24 hours in some studies, but not all. And in these studies, postprandial glycemic responses were measured infrequently with a long interval between the two test meal measurements. So the pattern of glycemic changes during this extended period is unknown. Whether the results from the lab can translate into free living condition is the question of our research, and to facilitate the answer, we use the continuous glucose monitoring system, which has been shown to better reflect glycemic changes under free living conditions than laboratory-based techniques in studies with adults. So in the method, this study was completed over 4 days, whereby participants' interstitial fluid glucose and physical activity were monitored using freestyle Libra and the actigraph accelerometer. So one day in the lab, we took the anthropometry, determined the VO2 peak, and physical maturation was self-assessed using secondary sexual characteristics. Then we showed the participants these pictures and we asked them to select the portion sizes that they believe would satisfy their hunger throughout the day. And the food items used in this study were chosen for its convenience in preparation, packaging, and in school storage. So after that, the participants came in the early morning to perform the 3 experimental conditions at the school on 3 consecutive days, where on day 2, they performed 30 minutes continuous brisk walking, and this is the moderate intensity exercise condition. On day 3, the no exercise control condition, and on day 4, they performed high intensity intermittent exercise involving 10 times 30 second sprints followed by 2.5 minute active recovery of brisk walking. So the 2 exercise sessions were matched in duration, but not in energy expenditure. Heart rate and rate of perceived exertion were also monitored during the exercise sessions. Then the participants consumed their selected meals at specific times and recorded that in a food diary. And we asked them not to just to consume water in between meals and to avoid any structured exercises throughout the rest of the experimental conditions. So the main outcomes are the 2-hour glucose incremental area under the curve after each meal and the 24-hour glycemic variability calculated as a standard deviation and mean amplitude glycemic exhaustion. So on the results, we have 14 mixed sample of healthy adolescents who were in mid-puberty, non-overweight or obese, and also non-trained. So in the results also, we can see here from this table showing the 30-minute exercise intervention that heart rate, RPE, speed, and distance covered were all significantly higher during high intensity exercise than the moderate one, showing clear difference in the intensity between the 2 exercise conditions. Regarding the glycemic outcomes, we can see from this figure showing the glucose incremental area under the curve at breakfast, lunch, and dinner for the 3 experimental conditions. So by looking at the p-value highlighted in gray, we can see that there's no statistically significant difference for the condition on the glucose incremental area under the curve after each meal. However, looking at the effect sizes highlighted in green, you can see that there's moderate to large effect sizes at breakfast and lunch, where glucose incremental area under the curve were lower during the exercise conditions compared to the control, but higher at lunch. Regarding the glycemic variability indices, we couldn't find any statistically significant differences between the conditions. So the possible reasons for the lack of the significant differences could be the small sample size. Free living studies require larger sample size to accommodate for the variability. COVID has impacted our ability to continue with data collection. Also, the window for change may be small in healthy young people with well-controlled glycemia, and it would be interesting to see this study repeated in adolescents with obesity or overweight. Another reason could be the nature of the test meal. The potential exercise effect may be seen after large glycemic exhaustion induced by oral glucose tolerance test, as we have seen in the lab, than regular meals. Okay, so I would like to thank all the participants, the undergrad students, and my supervisors for their contribution, and thank you for your listening.
Brilliant, thank you, Sahar, for nice, detailed and clear presentation there. And again, we'll please, if you do have a question for Sahar, please add it to the chat and I'm sure she'll answer it, or save your question till the end of this session. We'll move on now to our next speaker, Kamilesh Jay. Another PhD student within ISPAR, Kamilesh, is actually in the final stages of his PhD now, currently writing up his thesis, and he's going to present on one of his laboratory studies. So Kamilesh, did you want to get your slide up, share your slides? Okay, thank you, Kamilesh. So this study then focuses on the potential impact of breaking up sitting time on postprandial cardiometabolic responses, specifically in overweight and obese South Asian adults. Okay, over to you, Kamilesh.
Okay, thanks, Julia. Good afternoon. Today I'm going to present one of my PhD study, the effect of breaking up prolonged sitting on postprandial cardiometabolic disease risk markers in overweight and obese South Asians. Let me talk about a little bit background. So first of all, we should know who is South Asians. Basically, South Asians are individuals who born in the UK or migrated from the Indian subcontinent, country like Bangladesh, India, Pakistan, Nepal, and Sri Lanka. Based on the previous findings, South Asians are at higher risk of cardiovascular disease and type 2 diabetes compared to any other ethnicities living in the UK. And it may be possibly due to their body fat composition. And do we know that postprandial glycemia and triglyceride are associated with developing cardiovascular disease and type 2 diabetes? So there is, based on the previous findings, breaking up sitting with 2 to 5 minutes exercise can improve cardiometabolic risk markers in overweight and obese Caucasians. However, there is no enough evidence in South Asians whether they can improve in these activities. Only one study can examine like intensity exercise for 5 minutes every 20 minutes can improve postprandial insulin in older South Asians. However, the effect of breaking up sitting with light intensity exercise on cardiometabolic disease risk markers in overweight and obese South Asians remains unknown. Therefore, this study is conducting to examine whether breaking up sitting with light intensity walking can improve postprandial cardiometabolic disease risk markers in these groups. Let me talk about study methodology. This study was a 2-condition randomized crossover trial for 5 hours condition. One was sitting condition throughout the 5 hours period, and another was interrupted sitting condition. 19 overweight and obese participants took part in this trial. This is the symmetric diagram. So this 5 hours condition was divided into two periods. One is breakfast postprandial period, that was 3 hours period. Another one was lunch postprandial period, that was 2 hours long. So in the morning, participant came around 8:30 in the morning. So at baseline, their blood pressure, their blood sample, and their expired sample was checked to measure. Blood sample was collected to measure blood glycemic index, their insulin, and their triglyceride. And from blood pressure, we measured mean arterial pressure and heartbeat. And from expired air sample, we measured fat oxidation, carbohydrate oxidation, and resting energy expenditure. Throughout the period, let me mention there is a meal we provide to lunch and breakfast. So every meal contained high glycemic index food, micronutrient there, 58% carbohydrate and 28% fat, and 13% protein was there in the breakfast. And lunch was provided same micronutrient. However, there is a little, there is glycemic index of 73. And we can see here, there is a treadmill walking board for participants break up their sitting time every 30 minutes, they walk for 5 minutes. So altogether, they perform 45 minutes exercise in their breaking up sitting condition compared to their prolonged sitting. So let me share the findings. So based on the intervention, there was a trend for reduction in postprandial glycemia. So however, the effect was not significant, but the approach significant. It was a 0.04, and there is a small effect size was observed. So we can see from the figure, the star indicates there is a trend of significant difference in postprandial glycemia. But interestingly, if we see there is a post-glycemic over the time, we can see there is a significant difference, and the effect size was 0.37. There is quite comparatively large than the area under the curve analyzed. However, there is no significant difference observed in postprandial glycemia, postprandial triglyceride, and plasma insulin. So if I see from the figure, but if we in the analysis, if we look at over the time period, so if we see from the figure, there is a trend for reduction. So it was 0.04 significant below, and effect size was 0.19. But in the insulin analysis, there is no significant difference. However, there is a large effect, there is a medium effect size was observed, like 0.83. Resting energy expenditure significantly increased in the intervention period. If we see from the figure, the postprandial resting energy expenditure was significantly increased in the breaking up sitting condition. And in both period, if you look up over the time, there is a more increased, like P below was like less than 0.001, and large effects, medium effect size was observed in resting energy expenditure. But there is, however, there is no significant difference observed in resting fat and carbohydrate oxidation and mean arterial pressure and heart rate. But if we look at the condition over time, there is a time point, we can see there is a significant increased. The fat oxidation gone up and the carbohydrate oxidation gone up similarly in intervention period. This means exercise can increase their increase the metabolic rate. So let me summarize the findings. So breaking up sitting with 5 minutes of light intensity walking every half an hour can acutely improve postprandial glycemia, triglyceride, resting energy expenditure in overweight and obese South Asians. So this intervention could play a crucial part in improving cardiometabolic health in overweight and obese South Asians. Further research should investigate the efficacy of this intervention. Like further research could use like more, they looked at more intensity, like moderate to vigorous intensity. Duration could be more frequent breaks to reduce prolonged sitting in South Asian community. Thank you. Any questions?
Thank you, Kamilesh. Another really good presentation there. And again, we'll save questions until the end, but please do ask Kamilesh if you do have a question now. Add it to the chat, and I'm sure Kamilesh can respond either in the chat or we'll save the question and I'll ask it at the end of this session. Sorry. So well done, Kamilesh. And now we're going to move on to Abby Bell, another one of our PhD students within ISPAR. So Abby's research is also looking at the impact of breaking up sedentary time, but in a different population. So she's actually looking at patients who are going through cardiac rehabilitation. So this is an at-risk group clinical population here. So Abby, when you're ready, can you just share your slides? Okay, brilliant. Over to you, Abby.
Brilliant. Can you see them okay?
That's perfect. Yeah, if you just want to put your screen onto full screen, that's it. Okay, you're ready to go.
That's great, thank you. So as Julia said, I'm a PhD student at the University of Bedfordshire. I also work in cardiac rehab, so I'm going to be talking to you today about one of my studies that forms part of my PhD, looking at sedentary behaviour in cardiac rehab. And the title of this study is Reducing Sitting Time with Standing and Light Activity in Free Living Conditions on Glycemia Post-Myocardial Infarction. So a bit of background, first of all, I think is quite important to set the scene for this study. So cardiovascular disease, you may have heard this term before, one of the most prevalent diseases for both morbidity and complications and mortality across the world. And in the UK alone, approximately 7.5 million people are living with cardiovascular disease. It's quite a significant amount of people just in the UK. Cardiovascular disease is an umbrella term which is used to describe a range of heart and circulatory conditions. And these include ischemic heart disease, peripheral arterial disease, and stroke. So today I'm going to be making reference to ischemic heart disease, a type of blockage in the arteries, and more in the form of a myocardial infarction, MI, which you may know as a heart attack. So There are a number of risk factors for an MI, one of which is sedentary behaviour, which I'm going to be talking about today within my study. This has been somewhat of a bit of a focus across today's conference, but just to reiterate, it's defined as sitting or lying down for a prolonged period of time without moving. Now, previous research has shown that sedentary behaviour has a significant effect on increasing cardiometabolic risk markers, so things such as increasing blood pressure, cholesterol, glucose, and so on. Now, once somebody's had a heart attack, there's a bit of a focus of a tighter control on these risk factors, hopefully to prevent them from having another one in the future. So while we know there's an association between sedentary behaviour and cardiometabolic risk markers, the good news is that we can do something about them by reducing and breaking up sitting time each day. So you can see here a study conducted by my supervisor, one of my supervisors, Daniel Bailey, and his colleague in 2015, where he found that by breaking up sitting time every 20 minutes with 2 minutes of light activity, so walking, at about 3 miles per hour, kilometers per hour, it had significant effects on reducing plasma glucose. And you can see that in the lower curve on the left there on that graph. This was compared to prolonged sitting in healthy young individuals, so people hopefully that don't have many cardiovascular risk factors at a young age. And this was reduced by up to 20% by breaking up sitting time with light breaks compared to uninterrupted sitting, so quite significant effects. Now, we can also observe similar effects in overweight and obese individuals, and Kamilesh touched on that nicely as well with South Asian individuals, where plasma glucose can be reduced as a result of interrupting sitting time with both light and moderate intensity activity. Now, these effects are often exacerbated in those that are metabolically impaired, so those that have impaired glucose tolerance, their body can't produce insulin as easily, type 2 diabetes, and a lot of these comorbidities are very similar to cardiac patients. So that takes me nicely onto my study. So the aim of this study is to determine whether there are similar effects in a cardiac population when we look to break up their sitting time on glucose following a heart attack compared to prolonged sitting. And we're doing that in their own usual environment, hopefully at home or whether they're at work, and we refer to this as free living conditions. So this is a repeated measures randomized crossover study design where participants are used as their own control group. So hopefully we can minimize the risk of confounding variables and other factors that may play into reducing the risk, reducing glucose effectively. So when participants are first recruited, we'll take their anthropometric measures. So we'll take things such as their height, their weight, their waist circumference, and then they're asked to do a tryout day, just to check their compliance with the protocol before we enroll them onto the full study. So they'll be wearing a thing called an active PAL, which is an accelerometer that has a built-in inclinometer, so we can see changes in posture when we do this. And I think a few of my colleagues today have used similar technology. They'll then have to comply with condition 2, which you can see listed on the presentation here, where they'll be sitting, and prolonged sitting will be broken up every 30 minutes with either 5 minutes of standing or self-paced light intensity physical activity. If they're then able to complete the tryout day, hopefully if they do, they'll then enroll onto the study. So this is 11 days in total, and they'll be randomized to one of the 2 conditions you can see listed here. So for their first condition, so either prolonged sitting or every 30 minutes during waking hours, they'll break up their sitting with 5 minutes of standing or light activity. During this time, they'll be wearing an active PAL throughout the trial, and you note that there's a 3-day washout period there to hopefully reduce the risk of any trial crossover effects. And then alongside the active PAL, they'll be wearing a continuous glucose monitor. So this is a little handy device, as you can see here, that just sits on the back of the arm, and it continuously measures interstitial glucose up to 14 days. So we're using this across 11 days. And you can see here, this is our primary outcome measure for the study. We also have some secondary outcome measures. So these are blood pressure, which we'll be taking every waking hour on the hour throughout the condition, alongside mood and well-being, which will use the positive and negative effects scale, a questionnaire at the beginning and end of each condition to see how these vary across the two conditions when comparing sitting to breaking up and reducing sitting time. Participants will be recruited from the cardiac rehab programme at Bedford Hospital following a heart attack within the past 12 weeks. It'll be their first heart attack without a complicated procedural recovery. I'm quite fortunate because I also work here part-time, so it puts me in a really good position to help people with sedentary behaviour and hopefully their recovery as well. So we haven't got any findings yet. Our expected findings, though, based on previous findings within both healthy and cardiometabolically impaired individuals, would expect to see that the interstitial glucose is significantly reduced by reducing and breaking up sitting time compared to the uninterrupted sitting group within this population. And hopefully will improve blood pressure and mood and well-being as well. So the implication of our findings, there's quite a few. So there's a potential that we can further reduce the risk of a secondary cardiovascular event by more tightly controlling the risk factors. So alongside medications and traditional cardiac rehab with exercise, we can also regularly break up the sitting time to help even more tightly control their glucose and their blood pressure and so on. And this can help us to inform local, national, and even international guidelines. There's cardiac rehab across the world. Obviously, people are having heart attacks across the world. It will also help to inform compliance for chronic intervention within cardiac rehab patients to reduce sitting time, hopefully over a longer period of time, which would also form sort of the next project for my PhD research. And then going forward, based on findings here in the future, we could also expand this research into other cardiac populations, such as those that have had quite complicated procedure or recovery, those with heart failure, where this kind of activity might be a little bit more suitable and achievable for those who aren't able to do a lot of exercise as part of their rehabilitation, or those that have had surgery in the earlier weeks, such as a bypass or a valve repair. So that takes me to the end of my presentation. Thank you for listening. If you want to pop any questions in the chat, and I'll try my best to answer them in the next question and answer session.
Okay, thank you very much, Abby. Another brilliant presentation there. We're going to move on now to our final speaker, which is our second keynote speaker, Ben Mailer. So Ben actually completed his PhD well, over a number of years, and finally completed, I think, was it last year, Ben? Did you receive your notification?
Yes,
yeah. Under Dan Bailey and myself in the area of breaking up sedentary time, really. And he's since gone on to become a researcher at the University of Leicester in the diabetes unit there, and he's going to present on a recent study that he's been working on. So this is a multi-component behaviour change intervention to reduce sitting time in office workers. So without further ado, I'll pass on to our alumni keynote, Ben Mailer.
Thank you very much, Julia. So yeah, as Julia just mentioned, I was at Bedford. I left in 2018, but due to COVID, my actual PhD completion was delayed somewhat. So regardless, it's great to be able to come back and just talk a bit about what I did near the end of my time at Bedford, but also what I've been doing since I left. Is that working? Yeah, brilliant. So I'll just depict this in a graph because I love graphs. During my PhD, I did a few acute studies, a bit like some of the ones you've just heard about. And then near the end of my PhD, I did a short-term efficacy study. And then I was lucky enough to get a job at the University of Leicester working on a larger workplace intervention. So my talk's going to sort of be a narrative one about these two studies. Luckily enough, there's been a few mentions about the detrimental effects of sitting, but I just want to focus on office workers briefly, So the average UK adult sits for about 60% of the day, whereas office workers, it tends to be a bit higher. And during work time, you actually see that over 3/4 of the time is spent in sitting bouts due to the nature of their job. And during these interventions, we measure physical health outcomes, but we also measure a lot of work-related outcomes and psychological outcomes too. And being in the workplace, we're able to assess presenteeism, which is a big thing at the moment, which is essentially linked to productivity, and also workplace absenteeism. So both of these workplace interventions follow a similar type of design in that we will recruit office workers who have desk-based jobs within those offices, and we'll do a batch of health assessments, but also questionnaire booklets which contain several validated questionnaires. And we use the Active PAL in both of these studies to measure sitting time as the gold standard device in our field. We'll then randomize the clusters. So for anyone that's not aware, a cluster randomized control trial is very similar to an RCT. However, when we randomize people, we randomize them by the cluster, which is typically their physical office environment, into a control or an intervention group. This is purely because you don't want to be trying to change someone's behavior in an office if they've got someone sat next to them who is in the control group. So it just reduces that contamination effect. Once they've been randomized, so for the first intervention, which was this short-term efficacy study, we provided an educational presentation to participants. We got them to have meetings within their office clusters to discuss, brainstorm ideas about how they might reduce sitting within their office space. Then there were also some individual elements, so weekly individual phone calls, which used motivational interviewing. All participants were also provided with a pedometer so that they could track their step count, and there was a step challenge which was engaged with a lot more than we thought would actually happen. So we rolled out that intervention, and then 8 weeks later we measured their behaviour again, and we did the same batch of assessments. So these are the main behavioural outcomes. So this is during work time. So the main outcome was to reduce work time sitting. We didn't actually find a significant reduction in work time shift work. But when we look at time spent in prolonged sitting, we see there's nearly a 40-minute reduction in those prolonged sitting bouts. And this is sort of verified with these number of sit to stand transitions. So what you're getting is 40 minutes less time spent in prolonged sitting, but also 8 extra transitions per shift, which was approximately 1 extra an hour. So kind of justifies that the educational presentation and the key messages we wanted participants to get from our presentation really hit home. So they weren't able to necessarily reduce their sitting time, but when they were getting up, they were also significantly increasing their stepping time. So it was a short-term intervention. It was quite intensive. Trying to call 45 people for a 15-minute motivational interviewing phone call every week was obviously challenging. But there were some really good results around the prolonged workplace sitting being replaced with that stepping. There is this barrier, and it's a challenge we hear a lot about in focus interviews, and a lot of publications report the same thing, which is employers expect their employees to be sat at the desk, otherwise they're not working. So there's that big barrier around that. All the health measurements that we took, we didn't actually see any significant effects to that. However, it was only an 8-week intervention, so it's probably too short to do that to see that effect. And what happened near the end of this study was a publication in the British Medical Journal. So this is the SMART Work trial. So SMART Work being an acronym for Stand More at Work. And it's quite a prestigious journal, the BMJ, especially for this type of intervention, because they saw over an hour reduction in sitting. And this was in office workers in Leicester, using a multi-component intervention, but adding this height adjustable desk like you see in the picture. Now, what had happened is they'd gained extra funding to continue this study into Smart Work and Life. And I applied for the job as I was getting close to the end of my PhD, and I was fortunate to get it. So what this study looks to do is to have the same intervention, adapt it slightly and improve on it based on the previous findings. But then also to add this component where we're measuring the intervention with or without one of these height adjustable desks, because they represent quite a significant capital investment for employers. An electrical desk can cost over £1,000. The ones we used in this study were about a third of that price. So it's important we can justify the use of them. The protocol's published. The main outcomes paper is being submitted hopefully this week, possibly next week. And the NIHR report is also in, and it's currently under review. The intervention itself is another multi-component intervention, so it has plenty of organisational, environmental and individual strategies. The key thing I want to focus on is that it's a workplace champion delivering this intervention. So we provide emails to them to send out every month. The workplace champion is a participant within the cluster, so that they're known by the participants. And they also organise group catch-up sessions and put posters around their office, depending on the office. So it's kind of tailored by the workplace champion to that office space. So all of that sort of builds into this package of the Smart Work and Life intervention. We recruited across 6 different local authorities using 2 different sites. So I worked at the Leicester site, and there was another one up in Salford, University of Salford. And similar to the RCT previously, we've got this standard care group, which is essentially the control group. But then you've got the intervention without a desk, and then an intervention with a desk. So we're not talking about an electrical sit-stand desk here. We're talking about a height adjustable workstation. So as you can see, it goes on top of the desk, and it allows a participant to switch between sitting and standing within a matter of seconds. The main thing being that this is about a third of the price, but has the same function. We then followed up at 3 and 12 months. We were due to follow up 24 months in, but that was last summer, and I don't really need to go into the details of why we couldn't do that. But essentially, all the office staff were working from home at that point. So we've just had to cut that short and use the 12-month data. So this is our main outcome. I will just mention that only the participants and the local authorities have actually seen these results up to now. So there's a bit of a sneak peek of what's going to be in the main outcomes paper when it's published. So you can see that with the blue bars, the intervention only group reduced their sitting by approximately 20 minutes, and this was retained at the 12-month follow-up, whereas the addition of this desk added an extra 40-minute reduction in overall sitting time. What's really encouraging to see is that when we look at the 3 to 12-month data between the groups, they're actually similar. And what you do see in some studies a bit like this is that there's an initial uptake in the intervention, but then by the next follow-up, there's a bit of a relapse. So it's really good to see that there seems to be sustained behaviour change here. The majority of the sitting happened, the majority of the reduction in sitting happened during work time, and it was replaced with standing, which makes sense based on them being given a desk in the desk group. And then we're not sure exactly why, but the intervention group, majority of their time was replaced with standing. So there wasn't really a change in walking like we saw in the previous study. Another thing to note here is that these results, although they're not quite as large in terms of reduction in sitting time as the Smart Work study, this is got more of a real world application. So there's much less researcher burden in delivering this kind of intervention, because it's on the workplace champion and on the employers to actually run it. We saw some other psychosocial benefits. So there was a reduction in self-reported stress, an improvement in well-being and work engagement, as well as a lot of reduction in musculoskeletal pain, so particularly the lower back and the feet, knees and ankles. Just a quick note on impact. So based on Smart Work, we've launched a website, which is smartworkandlife.co.uk. And the findings from Smart Work and Life will also go into this resource. It's a set of free resources for managers, workplace champions and individuals to help reduce their sitting time. And we're also in discussions with the local authorities about embedding that as part of their CPD programme. just very quickly say thank you to, so these kinds of studies require lots of expertise. There's cost effectiveness analyses that we'll be doing to see if the desks are economically viable, for example. So there's a lot of researchers from different institutions which have really contributed their expertise to these studies. And probably most importantly is the 855 participants who took part in both of the trials. I have tweeted some of the links. It should have gone out while I'm talking. If any of you are interested in the intervention or the protocol for the Smart Working Life study, that's on Twitter. I can put it in the chat as well. But yeah, thanks for listening.
Hi Ben, thank you for your presentation. It's really good to see, you know, what work you've been up to since leaving the university. So I'm really happy to say we're bang on track in terms of timing. So we've got 5 minutes for questions now. These are questions to everyone in this segment. So that's Dora, Sahar, Kamilesh, Abby and Ben. If you have a question, please raise your hand or add it to the chat or just speak. That's absolutely fine. So I'm just going to go through and start from the beginning. Right, so we'll start with Sahar. I know you've answered this question anyway, but perhaps you can elaborate a little bit more. So Ben's asked whether you looked at sleep characteristics the night before each exercise day and your control condition, as that could impact glycemia. You're still on mute, Sahar. So that, yeah, just a reminder to all speakers when you take your microphone off mute when you're answering.
Yeah, in terms of the monitor, we just asked them to wear that monitor during the waking hours. So it wasn't for 24 hours. So we don't know the sleeping pattern, I think maybe. Yeah, and how would that affect the glucose? Because yeah, we don't have the sleeping pattern data to compare that with the glucose outcome.
Okay. It's an interesting question. It might be something to look into afterwards, see if differences in sleep can affect glycemia in this population. So yeah, thank you for that, Ben. Another question from Ben to Kamilesh. In your interrupting sitting condition, what was the cumulative energy expenditure of the combined breaks?
It was like 273 kilocalorie in sitting interrupting braking condition, and sitting condition was 212. That means 26% higher energy expenditure was in braking and sitting condition. It was higher, 26% higher.
Okay. Yeah. So is that similar to your studies, Ben?
We're on the spot there. I think it is similar. Yeah, it's sort of between 250 and 300.
Yeah.
Yeah, 273. Yeah, and percentage was 26% higher in interrupting sitting condition. Good.
Yeah, so it's important to know these details because obviously Kamilesh hasn't compared Caucasians to South Asians directly. So if we know the energy expenditure, we'll allow for that direct comparison a little bit more. Good, thanks for your questions, Ben.
Thanks, Ben.
Right, we've got a question from Arena to Abby. Did you find any challenges in delivering PANAS to non-native English speakers?
Great question, thank you. So we haven't actually recruited for the study yet, but as part of the cardiac rehab program for safety, participants would need a translator if English isn't their native language. So we would always have a translator to help participants with that sort of thing. So in a long way of answering, no, I haven't come across it yet.
All right, thank you, Abby. So great, we've got quite a few questions actually. I'll go up to one for Ben. Did anyone experience any leg swelling, stroke aching as a result of standing for prolonged periods of time?
Yes, so I actually ran all the focus groups and interviews on participants. So I think we did focus groups on about 25% of the participants, which is a couple of hundred. So yeah, there is an initial. Normally, there's an initial bit of discomfort in the feet, leg swelling, things like that. The way we always sort of prescribe it to participants when they get the desks is to not try and stand up all day the next day they've got it. So it's a case of gradually building up to standing more. So yeah, they do feel it a bit, and we do get a few people that email us saying that they feel like they're being worse, that they're experiencing worse symptoms because of it. But once you get used to it and you appreciate that it's not just about suddenly going from sitting for 6.5 hours in a work day to sitting for 3 hours, so standing an extra 3.5 hours. It's about building it up, but also doing it in small bouts. So some people might just do it for 10 or 15 minutes at a time. And that's why these desks are so good, is that you can flick between sitting and standing in a matter of seconds. So yeah, little and often, and then gradually building it up to standing more is the key message that we normally say to the participants.
Great, thanks, Ben. And we just have one more question for Sahar here. So this is from Rob Salvaggio. During pubertal development, there are hormonal changes such as transient increases in insulin resistance, and we know they recover by the end of puberty. But was it possible for you to accommodate for this in your study?
Yeah, I think because of the small sample size, we couldn't actually include the pubertal, like the assessment of the Tanner stages or pubertal status as a confounding factor. So in the statistic, we couldn't account for that due to the small sample size. We were just focusing on the effect of the exercise on postprandial glycemia as a main outcome. But it would be interesting to maybe separate all the stages and see the differences between the effect of exercise throughout the different stages in puberty.
Yeah, I guess if one of your outcomes is that we need to test adolescents that might have pre-diabetes or a degree of insulin resistance or are overweight or obese, we could test participants who are actually, right in the middle of puberty, and you might see a higher likelihood of detecting significant effects.
Yeah, maybe.
Yeah, so good. But yeah, unfortunately, it's not always possible to count for all these confounding factors with our sample sizes in most of our sort of physiology, metabolism studies. They don't always permit for this. Perfect. All right. Thank you very much, everyone, for attending. So we've got 2 minutes left, I think, for a short close from Angel. So I'll hand back to Angel now just to close day one of the conference.
Thanks, Julia. Julia, thanks for chairing that session. And thank you to everyone for being part of our conference. I just want to say a big thank you to our speakers. We had a fantastic keynote from Stacy first thing this morning, and also our alumni keynote, Ben. So thank you for coming back and sharing where you're up to so far. And to our other speakers, to Abby, Fanny, Jamie and Jane in the first section, and then Dora, Sahar, Kamilesh and Abby in the second section. Hopefully it gives you a flavour of the work that's going on in ISPAR, the research that we are involved in, and the impact that, that the research is having to the health and well-being of our populations that we work with. I'd really encourage you to engage with us and get involved where you can. We have our social media profile, and we're always keen to hear from potential collaborators, people who would like to link in with our research. So do get in touch. I also want to say a big thank you to lots of people behind the scene, in particular Julia, who's really kind of led the ISPAR conference in terms of our organising committee. Everyone who sits on that organising committee, big thank you to them, and a thank you to Mike, who's in the background streaming this on YouTube, and our administrator Jane, who's helped get things sorted, and also to our faculty marketing administrator who's put our programme together. And if you haven't been able to see our programme yet, do have a look online, because all of the abstracts of all of the talks that you've heard today are available in our programme. As I said, it's been streamed on YouTube, so if you wanted to watch one of the talks or the whole session again, you'll be able to catch up, and we'll be sure to tweet out those links if you've missed them previously. So I think that's all from me. Thank you very much. Hope to see you again for our annual conference next year, and hope to speak to you before then. Have a great day. Take care.